had lost a lot of weight.
I think we're good, Megan. Thanks. Thank you, everyone, for taking the moment to watch that video. I'll mention again today that in the United States, there are over 11 million Americans who are providing unpaid care to a loved one living with Alzheimer's. And while we typically think of Alzheimer's as an older adult disease, I wanted to share a few reflections on who these caregivers actually are. So especially if you're a number lover, only 1 in 3 caregivers are actually over the age of 65. 2/3 of caregivers are women, and half of those 11 million Americans are caring for a parent or older a relative. In addition, 1/4 of all caregivers live in what we call the sandwich generation. We are caring up for an older parent or relative, but we still have school-aged children at home that we're caring for. So if you are a caregiver yourself, if you are supporting one, if you are working with caregivers, Megan is also dropping in the chat for you 2 other links. One is to our caregiving website with an array of resources and additional links. And the other link is specifically to tips for managing the holidays as a caregiver. And we know we are high in the holiday season and many to come in the next 2 to 3 months. So I hope that you will make use of those resources and share them as well with your clients and your family members. And now I believe I've got control. And so welcome to our program today. As Megan mentioned, we're going to be talking about the new treatments in Alzheimer's. So we'll be talking about the current FDA-approved treatments for Alzheimer's. We're going to explain the impact of these anti-amyloid treatments on the brain, talking about the benefits and also the side effects. We will visit the pathways to access treatment, and then we'll talk about some additional resources, and we are leaving plenty of time for Q&A and reflection. So again, please, throughout this afternoon's presentation, drop your comments or questions in the chat or the Q&A feature. Let's talk first about why this treatment is so important. Today, over 6 million Americans aged 65 and older are living with dementia due to Alzheimer's disease. And again, as I mentioned, 11 million Americans are providing unpaid care for people living with Alzheimer's or other dementias. We project that by 2060, we will be looking at almost 14 million Americans living with this disease. It's an exciting time, however, in research. There are promising new treatments for people living with Alzheimer's and other dementias, and it is exciting to say confidently that we have indeed entered the era of treatment. The treatments that we'll be discussing today actually change the underlying course of Alzheimer's disease. And by slowing down the progression of this disease when taken in the early stages of Alzheimer's, individuals will have more time to actively participate in daily life, have sustained independence, and hold on to memories longer. This is also why early detection and diagnosis are so important. Dr. Alois Alzheimer's first described the hallmarks of Alzheimer's disease in 1906, and that's what we know today and talk about as the plaques and tangles in the brain. Between 1996 and 2014, a variety of medications came through FDA, Federal Drug Administration approval, and Centers for Medicare and Medicaid, CMS coverage. You very likely heard of these: Aricept, Exelon, Razidine, Namenda, Namzaric. These medications are very effective in helping to manage symptoms of Alzheimer's disease and some of the behaviors that develop. They do not, however, change the underlying progression of the disease. In 2021, we had our first FDA-approved anti-amyloid treatment come on the market, Aduhelm. And most recently, earlier this summer in 2023, the second medication was FDA-approved Leqembi. These drugs are different than the earlier class of medication because they slow down disease progression by targeting the underlying biology of the disease process. And I'll talk a little bit more in detail in just a moment. Although Alzheimer's is a complex disease and scientists do not yet know completely the underlying causes of the disease, we do know that there are numerous contributing factors, including inflammation in the brain, vascular changes, metabolic changes, and the buildup of proteins in the brain that we know as tau and beta amyloid. The tau protein helps keep our brain cells healthy and allows for nutrients and other essential supplies to move throughout the cells. In some people, however, tau becomes twisted, causing what we know as tangles that build up inside of the cells. And where these tangles are forming, the nutrients and other essential supplies can no longer move throughout the cells. So in essence, these tangles are contributing to the death of the cell. Beta amyloid is another protein that is naturally produced in our brains. However, when beta amyloid clump together, they create amyloid plaques. And many researchers believe that these small clumps of beta amyloid are also contributing to cell death and tissue loss that we see in the brains of individuals with Alzheimer's disease. So ultimately, these plaques are also destroying the cells and therefore impacting an individual's ability to function. In the most non-scientific explanation, I like to say that the buildup of these proteins beyond what is normal in our brain is causing a loss of pathways and communication across our cells and cell destruction. And that is in fact what is causing cognitive decline, memory loss, and function decline that we see in Alzheimer's. Aduhelm and Leqembi are the first FDA-approved drugs in a class of medication that we call anti-amyloid monoclonal antibodies. How these work is that they attach themselves to the beta amyloid and actually reduce and remove the beta amyloid in our brain. Aduhelm and Leqembi work differently in how they target the beta amyloid at different stages of plaque formation. Clinical trial participants who received these treatments experienced reductions in cognitive and functional decline, which essentially means these treatments slowed down the disease progression. Now, these treatments target the amyloid development very early on. So individuals who are eligible or appropriate to benefit from these treatments usually will have mild cognitive impairment due to Alzheimer's disease or be in the very early stages of Alzheimer's disease and also have evidence of the buildup of amyloid in the brain. Though not a cure, these treatments are pivotal. They change the course of the disease in a meaningful way for some people. They are giving people more time to participate in daily life and to live independently. Cognitive decline, memory and thinking, and functional decline, for example, our activities of daily living, cooking, cleaning, managing personal finances, are reduced in individuals that have taken these treatments. However, like any treatments, there are side effects. The most common side effects in this class of medication are amyloid-related imaging abnormalities, or what we call ARIA, as well as infusion-related reactions. Headaches, falls, dizziness, nausea, confusion, and vision changes are all possible side effects. ARIA is a common side effect that typically does not cause symptoms. And although it can be serious, it is a temporary swelling in the area of the brain, or it can lead to small spots of bleeding in or on the surface of the brain. It generally resolves over time by itself, and most people who experience this do not have noticeable symptoms. So serious, but rare. Now, there are individuals that carry the APOE4 gene that may, in fact, cause an increased risk for ARIA. So the Federal Drug Administration is recommending genetic testing for the APOE4 status prior to the initiation of treatment in order for physicians and patients to talk about risks and benefits in taking the medication. Both Aduhelm and Leqembi are administered intravenously through an IV infusion. Aduhelm is administered every 4 weeks. Leqembi is administered every 2 weeks. Each treatment is expected to last 45 to 60 minutes. And in general, these treatments can be handled at hospitals or infusion therapy centers. Now, it's unclear how many doses an individual will need to take over their course of treatment. In clinical trials, participants tested these drugs for 18 months. The FDA is also requiring MRI scans prior to initiating these treatments and throughout the course of treatment to monitor for the ARIA side effect that we were just talking about. As I mentioned earlier, potential candidates for these treatments will have MCI due to Alzheimer's or be in the very, very early stages of Alzheimer's with evidence of amyloid in the brain. Remember that this is a class of medication that is targeting amyloid and is slowing down the buildup of the amyloid. So physicians need to confirm the presence of amyloid plaque in the brain. Now, while the FDA requires confirming that presence, they are not specifying yet which diagnostic tests should be used. So physicians are really choosing among themselves. The Alzheimer's Association recommends that tests like cerebrospinal fluid analysis or amyloid PET imaging should be used. The FDA is also including a boxed warning in Leqembi's label to raise awareness about specific side effects and at-risk populations. Well, as we all know, nationwide distribution and implementation of new treatments takes some time. So we now have FDA approval and CMS coverage. We have more of these medications in the pipeline. We actually hope in the next 6 to 9 months to see the third medication in this class come through approval. But we continue in our country to have to build the infrastructure to support access to and the treatment themselves. For individuals who already have the diagnosis, the association is recommending that you talk directly to your primary care physician to really determine if you are a candidate and then to work within that particular health system and your insurance. Because these FDA-approved treatments are now available, it is more important than ever that individuals and families are having informed discussions amongst themselves and with their healthcare providers. If an individual does not have a diagnosis and yet has concerns around cognitive impairment, the association is recommending that you start with education, that you understand the 10 warning signs of Alzheimer's and the difference between warning signs that may indicate a more severe condition and some changes that are simply typical with aging. And a lot of the studies that we do, patients and older adults continue to report that they think cognitive decline is a normal part of aging when in fact it's not. It is also always an issue for individuals to feel comfortable approaching their physicians, but we certainly encourage that individuals, families, older Americans really start to self-advocate much more and talk to your physicians about your concerns. Let's talk a little bit about coverage for these treatments. So Leqembi and Aduhelm are covered in different ways. Aduhelm coverage is currently very limited. It was the first medication in this class to come out. For Leqembi, the Centers for Medicare and Medicaid Services have said that they will cover the drug as long as an individual's physician enrolls them in a CMS approved registry. And there are several out there. The Alzheimer's Association has one as well. That is to track the administration of these medications and the progress of them. Those who are eligible for both Medicare and Medicaid, either as a full benefit dual eligible or in a Medicaid savings program, can receive coverage for these medications. Typically, Medicaid's role would be then to cover 20% of the individual's coinsurance payment. There may be additional state requirements. Other insurance plans will likely depend upon your individual plan. So not all of the large private insurers are covering these medications yet. More information on coverage, as well as any additional prescription drug assistance, can be found at cms.gov. Megan, I don't know if you'd be okay plopping that in the chat. Again, it's cms.gov, where you can find more information. And the Veterans Health Administration has agreed to cover Leqembi for some of the veterans who meet certain FHA requirements. So we know these drugs will be of great interest to many people, and we have actually seen an uptick since July with the approval of Leqembi in calls to our helpline, as well as calls to our local chapter, people inquiring about access to the medication, people asking about referrals to neurologists and diagnosing physicians. So certainly of great interest and of great importance, but it is not the only important element of Alzheimer's treatment and care. So I did want to share, either for you as the caregiver or for the constituents and the clients that you're working with, some of our general resources. The 24/7 helpline is also available in 200+ languages, in addition to English. Our website, alz.org, has a myriad of resources, additional links, bulletin boards, community boards that you can join, as well as on-demand education programs. And then we work in communities across the country with partners, for example, like caring.com, to bring education and awareness to community members. And then for professionals, I wanted to share some additional resources. And again, this PowerPoint will be available to you. So these resources are going to help provide more detailed industry-specific information and resources. So for researchers, we have a site. For health systems and medical providers, for professional care providers, which would include long-term care, community care, home health, for public health professionals. And we also work a lot with first responders as well, and the work that they do in communities. So I would encourage visiting any one of these sites as appropriate for even more detailed, specific information. And someday we hope to live in a world without Alzheimer's and all other dementia. Thanks to all of you who are joining us this afternoon, seeking the knowledge, and to our partner, caring.com. Megan, I would love to turn it back over to you to spend some time in Q&A and sharing any comments that we've gotten.
Yes, no, that was an incredible presentation. That concludes the content portion of today's presentation. We do have a few questions coming through, one of which I did just want to ask in case anybody joined late. The slides and the recording for this presentation will be emailed out after the presentation sometime this afternoon or tomorrow. So I just wanted to kind of put that back out there, but we do have a couple of questions here. One of which is, will Medicare pay for these drugs, for these medications you spoke of?
Yes, Medicare has agreed coverage. Again, the stipulation is that physicians are required to enroll their patients in a CMS approved registry. And again, that is for tracking purposes across the country. That was a legislative battle that the Alzheimer's Association, among others, was engaged in really for the last several years. And CMS did change their minds this summer and made the decision to cover.
Another question we had coming through was someone mentioned they were listening to a natural medicine doctor, a homeopathic doctor, who stated that Alzheimer's is what they refer to as diabetes type 3 because of the buildup of sugar in the brain, and they want to know if there's any truth to this.
The association has no comment on that. I certainly anecdotally have heard that, and I will say that diabetes is among those additional risk factors for cognitive impairment, but we don't have an official statement on that philosophy.
Okay. And then somebody else had asked, is discrimination an issue in seeking an Alzheimer's diagnosis?
Yes, absolutely. And great question. I would like, in general, just to make you all aware that every March, the Alzheimer's Association publishes what we call our annual facts and figures report. And I think Megan is going to put a link to the 2023 report in the chat for you that is accessible to the public. Each issue includes a special report, so a deep dive into a particular topic. And the deep dive in our 2022 or 2021 report was actually looking at discrimination and access to healthcare. So that is a great resource for much more detailed information. However, I do want to share in response to that question that people of color and women are disproportionately affected by Alzheimer's disease. Black Americans are twice as likely as white Americans to get this disease. And yet, people of color report experiencing and perceiving discrimination in healthcare at a much higher rate. Therefore, while communities of color are at higher risk, they are experiencing discrimination and often culturally incompetent healthcare, and that is dissuading them from seeking early detection and early diagnosis, so that by the time they are getting diagnosed, they have progressed beyond the point of being eligible for these new treatments.
As a follow-up to that, somebody had mentioned that they are a DNP student and that they want to know if there's any way that they or other people in the senior living and senior care industry can help encourage those to seek treatment who may be impacted by discrimination or just like a lack of being able to seek care.
That's a wonderful question. And that's exactly the kind of work that we do on a daily basis. I would say that really you can enter the advocacy arena. You can certainly become an advocate, spend as little or as much time as you have pushing for legislation around access to quality care. And so on our general website, alz.org, I would invite you to visit that. If you scroll to the bottom, you will see learn about volunteer opportunities, and there's a whole section on what advocacy means and how to become an advocate. That work happens at the state level as well as at the federal level. And again, you can commit as little or as much time as you want. We do have, every state has a state advocacy day. Those will also be posted on our website. I can tell you in North Carolina, where I am, our state advocacy day will be in May 2024. At the federal level, we also have our national forum. That usually happens sometime February, March, or April of every year, and that takes place in Washington, D.C. Then I would say that working to make that difference, working to help educate communities of color, to better support them, really happens at the local level. So indeed, there are lots of ways to get engaged in raising awareness, in reaching out to these communities. Again, in North Carolina, and I would encourage, if anybody is in North Carolina and interested, we've put together a voluntary leadership group of Hispanic Americans who are really being the conduit into the Hispanic community to help educate folks. And we are simply trying to support them. So if you're looking to get involved locally, I would reach out to, of course, your local Alzheimer's Association chapter. You can find that on our website by state and then by county if we have multiple chapters. And also look at any of your area agencies on aging, for example, that are also doing work with communities of color and diversity. I hope that answered it. That was a very long answer to that question, but that was an excellent question.
We have a couple questions on stage of Alzheimer's and medication. Somebody asked, at what stage can patients benefit from this medication? Or is there a specific stage where this is going to be the most effective?
So yes and no, because everybody, of course, progresses through the disease at a different pace and to different degrees. So we can't say there's a universal starting point and ending point for eligibility in who will benefit from this. But we absolutely can say that this class of medications, the anti-amyloid monoclonal medications, are targeting the very earliest stages of Alzheimer's. So individuals with a diagnosis of mild cognitive impairment due to Alzheimer's, or the diagnosis of Alzheimer's in the very early stage, again with amyloid in the brain, are the ones who are going to be in the class of eligibility. They will most likely benefit from it. These medications have not been tested in clinical trials on individuals more progressed in the disease. Anecdotally, there will clearly become a time when there is too much amyloid buildup to be able to slow that down. So for many of us in senior industry, most of the individuals who are coming to us and living with us in assisted living or memory care are there because of the level of care they need and how far they have progressed. So they are likely not candidates for this treatment, but it's important for us to understand as much as possible about the treatment because, I anticipate if you haven't experienced it already, family members are probably asking a lot of questions because of the attention being paid to this.
And then just kind of in a similar vein, is there any chance of reversal in early Alzheimer's or dementia using these drugs? I know you mentioned as a slowdown, but is there a chance for reversing any of the side effects?
Nothing that indicates that. So again, these aren't a cure. They're not stopping the disease. They're not reversing it. They're simply, in this class of medications, they're simply slowing down the buildup of amyloid in the brain. So they are giving us more time. That was our campaign last spring, was #MoreTime.
Love that. And then we're getting a couple of questions on cost. If people want to know about the cost without insurance or with insurance, do you know where they could potentially find some of those resources?
I would start with that website, Megan, the cms.gov website that I mentioned. I think that's going to be the broadest. Probably a lot of digging and phone calls to your individual providers, because again, not all insurance carriers are covering this medication at this point.
Makes sense. And then do you know if there's a difference between how males and females are responding, or any signs of one gender over the other seeing better results from these kinds of medications?
I have not seen that in the information on the trials. In general, we are seeing that reduction in cognitive decline and functional decline. I haven't seen anything which suggests more of an impact in men or in women. That's a terrific question, though. So I will be digging around to see if there are gender differences. We know that women are at higher risk for Alzheimer's disease. We used to think it was because we lived longer, so we had more opportunity to be in that stage, that age risk factor. There's much more research now that's looking at gender differences and physiological differences that could be contributing to women's risk factors. So more to come on changing demographics in in our 2023 facts and figure annual report, there's a great special report, and it does talk a little bit about changes in demographics, and we simply don't know really yet, because the women that are aging today are aging with some of the lifestyle interventions that help to minimize risk. So it will be very interesting to see in the next 10 to 20 to 30 years, as this group of women age, how does that change and impact whether, the rate at which we're getting Alzheimer's disease, perhaps even the rate at how effective these treatments would be for us.
Of course. So I think we have time for a few more questions. Somebody asked, do you know if an MRI or a CT of the brain shows the amyloids, the area that you're looking for? I butchered the pronunciation of
It
that.
is the PET imaging that will show the pockets of amyloid. The MRIs, again, very non-scientific response. It's a combination of all of that imaging. The PET scans will show the pockets of amyloid, and the MRI will show, bleeding in the brain. The MRI can really be used to help monitor any risk or indication of ARIA, as we were talking about, because it's going to show shadowing in the brain. And both of those will become part of this process. They've been available in clinical trials for several years.
And then somebody was asking if you have any advice or tips on how to help a resident who may be having signs of getting Alzheimer's in their family, kind of come to terms, find resources, things like that.
So it's a very interesting phenomenon when again, this year's special report, I would encourage everybody to take a look at. It's looking at patient and physician relationships and perceptions and the differences. So the vast majority of older Americans say that they would want an early diagnosis. They would want to know. They say that they believe that cognitive assessments are an important part of their ongoing health care. And as we know now, cognitive assessment is included in the Medicare wellness visit. The vast majority of primary care physicians also say that it's important to talk about cognitive health, to do cognitive assessments. And yet, less than half of older Americans surveyed are actually getting those cognitive assessments and having those conversations. So it's a national phenomenon. There's clearly a disconnect. Patients want the physicians to raise the issue. Physicians are waiting for the patients to raise the issue. So very tricky, not uncommon. Every situation is going to be unique. Every family is going to be unique. So there isn't a good one size fits all answer to that. A lot of our care consultants will coach families that sometimes really focusing on that, the annual wellness visit and the cognitive assessment as a part of that may be a gentle way to raise this discussion. I've talked with folks and really encouraged all of us who are 65 or older to enthusiastically wrap our arms around getting that assessment, because you can tweak it a little bit. It's not that, oh, we think something's wrong with you. It's that assessment provides a great baseline. It allows you year after year to compare any changes you may be experiencing and how you're responding on those assessments. So that can be a very gentle way to raise it if you're getting some pushback from the resident or from family members. I would encourage bringing education into your community in a general way. So it could be some awareness presentations where we're just talking about brain health overall and what that means. So you're introducing the topic, creating a safe space for discussion, but not necessarily singling any one person out. A lot of people are still confused about what dementia is versus what Alzheimer's is. So that's a great topic for education as well, is to provide that clarity, those forums. And then for individual situations, I would absolutely encourage, whether it's our care consultants at Helpline through the Alzheimer's Association or care navigators in your own communities, in your local communities, that you can either utilize to come up with a plan, or you can encourage family members to talk with the care consultants or the care navigators. Again, they can bring kind of a more universal approach to clearing the air and building some safety and comfort in having the tough conversations.
Exactly. So we got a question about the infusions and whether they're going to be performed at home or do they have to go somewhere, kind of like a dialysis center for the infusions, for the IV infusions.
Great question. At this point, yes, the infusions are intravenous and they need to be done in a center. They need to be done by a healthcare provider. So hospitals can generally administer, or infusion centers can administer. But the good news is that researchers are looking at ways to develop these injections that individuals could do on their own. It's not possible now, but it's being looked at. So I would say it's down the pike. And it's like what we see with diabetes in diabetics being able to handle their insulin and inject their insulin. So hopefully that will come sooner rather than later. But right now, today, you do need to go to a center or a hospital.
And our last question here is, somebody wanted to know what kind of doctor would do the assessment to determine if a patient is qualified for one of these medications.
So another great question. Still today, most initial diagnoses are being done by primary care providers, who would then refer to a neurologist. So it's going to be your primary care provider who is the entryway, if you will. And then it's very likely that a PCP, depending upon the practice bandwidth, depending upon their comfort, may then refer out to a neurologist. So I hope that made sense. It does go back to some of the data that primary care physicians are certainly equipped to give. I mean, there is the information and the procedures and assessments out there for them to give a diagnosis of Alzheimer's, yet most of them still report maybe not feeling that they're adequately prepared to give the diagnosis. The majority of them will say they certainly don't feel prepared to treat and care for the patient following the diagnosis, and they often simply don't have the bandwidth in their practices. So starting the conversation with primary care physician, and then very likely that a neurologist would be involved.
Perfect. And that does look like it covers a bunch of our questions today. If anybody else has any more questions, feel free to submit them in the Q&A in the chat. And then afterwards, Courtney will go ahead and get some answers for you. And in our follow-up email, I will make sure to include any additional information and resources in there. Courtney, it has been such a pleasure collaborating with you on this topic and hearing about your expertise. I just want to give you a second to plug any programs or anything relevant from the Alzheimer's Association for this audience while you're here.
Well, thank you. And thank you everybody for joining us this afternoon. And Megan, it has been wonderful to collaborate with you. This is such a new topic. I mean, this is only since 2021 that we have had these treatments available. So there are a lot of questions that we can't answer yet. There's still a lot of infrastructure in, nationwide that we need to put into place for this. And it's going to differ. I just saw a question pop up in the chat. One primary care physician's comfort and understanding may differ from another one. So there's kind of that dissatisfaction in not having a clear path and set of steps. But that is part of our commitment at the Alzheimer's Association, our medical and scientific team, working with health systems to address, building up that infrastructure and that access. Would love, no matter what community where you are, if you're in North Carolina or if you are elsewhere in the country, would love for you to connect with your local association chapter. We'd love to do some of this awareness and education work that you've been asking about. We do have in North Carolina, our website is alz.org/North Carolina. You can visit that and see the list of programs that we offer both virtually and in person. If you are outside of North Carolina, you can go to alz.org and search for your chapter. And as Megan mentioned, we will take a look at the questions we didn't get to and spend a little time coming up with an FAQ that we can send out as well with this PowerPoint. So again, thank you to everybody who took their time this afternoon to join us and learn a little bit more.
Perfect. And I just want to say thank you all so much for joining. We at Caring welcome your feedback on today's presentation. And if there are any topics that you were interested in having us dive deeper into the future, we would love to hear it. There's going to be a survey that pops up as the webinar closes where you can let us know your feedback, any topics you're interested in, kind of giving your perspective, as well as by contacting the phone number and emails that are listed here. You can stay on top of Caring's upcoming trainings by following us on LinkedIn or visiting our website, partners.caring.com. And with that, we're going to let you all get back to your commendable work of helping seniors, and we hope that you all have a great rest of your day.